Once again, good morning, everybody. If you would do me an amazing favor, and probably not just for me, but for the amazing facilitators that are going to be feeling this, can you just come up a little bit? We ain't got to act like we so distant. Let's just come in just a little bit, come up. If you have to turn around, I'm talking to you. Just like like you the one. Like, let's just come up a little bit. Yeah. Let's just come up a little bit. Okay, all right. Ain't nobody gonna move. All right, it's all right. It's all right. I know, guys, you're not gonna get picked for nothing. It's just, because the reason that this is important, they're gonna be using the PowerPoint and they're not gonna be using the mics. Okay, so we just wanted to make sure that you can hear. So that was the reason for that. Thank you for those of you who gave the thought of moving. I appreciate it. Some of you lifted your eyebrows. I appreciate it. That's it. That's all I got for them. That's it. All right. But no, honestly, guys, thank you so much. Just like I said in the last group, it's super important that as you're coming to these sessions that, you're coming to get something, you're coming to obtain something. It's not just a simple monologue, but it's really a dialogue of you guys being able to engage with them. So same thing we did in the first session. I'm going to ask you 3 questions. You're going to give me the 3 answers. I'm going to ask you who's ready to learn. You're going to say, I am. I'm going to ask you who's ready to grow. You're going to say, I am. And then I'm going to ask you who's ready to win. Then you're going to say, we are. Your answers are, I am, we are. So what are your answers?
I am, we are.
Fantastic. Because, guys, as we come here to learn together, these individuals, just literally with the small time that I've spent with these 2 awesome ladies, they're passionate and they're excited about sharing this information with you. And I want you to connect with their energy. All right, so here we go. Everybody up. I know you can stand up. You ain't got to move. Here we go. We're going to do this. I need the people that's in the expo hall to hear this and feel bad that they're not in here. That's what I need to happen. Okay, so here we go. Who's ready to learn?
I am.
Who's ready to grow?
I am.
Who's ready to win?
We are.
All right, so now you can take a seat. Guys, I'm getting ready to introduce to you 2 phenomenal individuals. But before I get into that, I definitely want to take a moment to recognize our sponsors, Gilead and ASA, and especially Black Health Matters. Guys, let's give them an amazing round of applause. With Black Health Matters, guys, I'm going to be bringing up Mrs. Leslie Footnote, who is the Managing Director of Black Health Matters. Leslie is presently the Managing Director for Black Health Matters and a woman-owned, and she is fantastic. I've had so many bump-ins with her this morning, and that smile, her personality, but she's excited about what's happening here today. With Leslie, she is dedicated to improving health outcomes in the African-American community. She leads efforts to inspire and educate around health, wellness, chronic illness through the company's forum and virtual summits. Leslie is a proud mother of 2 young adults and honored to serve as a member of the Psi Omega chapter of Alpha Kappa Alpha Sorority Incorporated. So if you don't mind, she's going to come up and say a few words. Let's give Ms. Leslie an amazing round of applause.
Thank you so much for all of that. How's everybody doing? Great. You ready to be fit and fabulous right after today? We really will, with all those amazing vendors there and also all of you here and getting all this knowledge. So thank you for having us. This is really important and it's very special to us. We are a company that's 11 years old, believe it or not. We are a national company. We go around the country. We do forums, just as we talked about, as well as webinars. We have social media. Please visit us at blackhealthmatters.com, sign up for our newsletter, and hear about our summits that are online and in person in different cities. Who knows, we might be back to Dallas to do a full summit, a full day summit of education. So what I'd like to talk to you about really is the 2 areas that we'll be covering today. One is on GYN health and wellness, and specifically endometrial cancer. And the other will be on breast cancer awareness. And just so that you know, if you haven't had your mammogram in a year, we actually are offering free mammograms here. There's a mobile unit outside. It's free and open to anyone here over the age of 40. So please take part of it. So one of the big focuses really in terms of Black women, and then I heard just recently in this state that Black or women in general rate 49 in terms of health disparities and health inequities in this state. As Black women and women of color, we experience higher rates of death from breast cancer due to a combination of factors, as well as endometrial cancer as well. And that's something that people do not talk about. So in your chairs, and also if you come to our booth, we'll talk to you about Spot Her, which is an initiative that is designed to raise awareness of endometrial cancer. This is happening all over the country, this initiative, and it's also online. So we have this fanny pack you can wear below the belt. We'll have plenty of them you can actually take with you. And then also with Gilead, we're focused on breast cancer and also early detection as well. And also those that are living with triple negative breast cancer or metastatic breast cancer. With that, I'll turn it over to our esteemed panelists. Thank you.
Thank you so much, Ms. Leslie. Guys, I'm going to introduce to you two amazing individuals. One, Dr. Pinnapureddy. I got it, Pinnapureddy. I've been practicing these names, boy. There's some names on this list today. No, but Dr. Pinnapureddy is board certified in internal medicine and medical oncology. She specializes in treating all types of cancer, including breast cancer, kidney cancer, ovarian cancer, and prostate cancer. She is dedicated to providing compassionate and quality patient care in practice with the Center of Cancer and Blood Disorders. Also, I'm going to be introducing Dr. Latanja Robinson Brown. She specializes in obstetrics and gynecology. She has been in North Texas for over 20 years, and during that time, she has gained a multitude of personal and professional experience. She currently serves as a medical officer at Carswell Federal Medical Center with the Bureau of Prisons, which is the only federal medical facility devoted to women medical care in the Bureau of Prisons. She is also a charter member of Alpha Beta Iota Omega chapter of Alpha Kappa Alpha Sorority Incorporated. So I want everybody in the audience to do me a huge favor. I want you to say, ladies, teach me something.
Teach me something.
All right, let's give them a warm applause.
Hello, thank you all for having me. My name is Dr Pinnapureddy, and I'm a medical oncologist. I practice with the Center for Cancer and Blood Disorders, and my clinic is in Las Colinas, so it's about 15 minutes from here. So I'm just going to do a general overview of breast cancer, and if we have time at the end, we'll entertain any questions you guys have. So breast cancer, what is it? It is a disease when cells grow out of control, and there are different types of breast cancer. So it all depends on, it all depends on which cell grows out of control. Breast cancer can begin in the ducts or the lobules, which are parts of your breast, and it can spread to places outside of the breast through blood vessels and lymph vessels. So these are some risk factors. There are certain factors that unfortunately we have no control over. Gender, women obviously have a higher risk. Age, most breast cancers are actually diagnosed after the age of 50. So the older you get, the higher risk you have of getting breast cancer. Race, family history, like if you have a first-degree relative with breast cancer, that increases your risk. Menstrual history, meaning if you started your periods later or you started your periods earlier or you had children later, you have more estrogen in your body, and that increases your risk of breast cancer. And then having dense breasts. Dense breasts have more connective tissue than fatty tissue, and sometimes things are missed on mammogram if your breasts are very dense, and they may recommend you move forward with an MRI for some people. And then these are risk factors that you have control over. So hormonal factors, obesity, not being physically active is actually a higher risk of breast cancer. Being overweight or having obesity after menopause, older women who are overweight, they have a higher risk, unfortunately, of breast cancer as well. Smoking and alcohol definitely increase your risk of pretty much a lot of cancers, but also breast cancers. I don't know why I'm doing this. Okay, can you guys still hear me okay? Okay, sorry about that. And then reproductive history, as I mentioned, this is something I guess you have control over, but not necessarily. Having your first pregnancy after the age of 30, not breastfeeding, and never having a full-term pregnancy can increase your risk because of the amount of estrogen that you will have in your body. And then hormone replacement therapy after menopause, there's a lot of people who take hormone replacements, and unfortunately, it does help with your symptoms of menopause, but it can also increase your risk of breast cancer. So what is my risk of breast cancer? General population, 12 out of 100 women will get it. Women with one first-degree relative, like a sister, a mother, 24 out of 100 will get breast cancer. And women with two first-degree relatives with breast cancer, 36 out of 100 will get it. And then BRCA mutations, which is the genetic mutations that you can get tested for based on your family history, 40 to 85, I know that's a huge spread, but 40 to 85 out of 100 women will get breast cancer. So, I mean, this is a women's, panel and everything like that, but men can also get breast cancer. 1 out of every 100 breast cancers that are diagnosed are found in men because they also have breast tissue. It's not very common. I think I have probably 2 in my clinic, but it can happen. And so, oh, that was breast cancer? Okay. In the past, yeah. Yeah, I saw he passed away. Okay. He was treated for it, yeah. So, sorry. What are my chances of getting breast cancer? So 1 in 8 women, it's a high number. 1 in 8 women will be diagnosed with breast cancer in their lifetime. So breast cancer, goes from basically stage 0 to stage 4. And stage 0 is precancerous, but they still included in this group. 1 in 3 cancers of all new cancers in females a year is breast cancer. There's also lung, colon, and all that, but breast cancer is the most prevalent. And in 2023, the American Cancer Society's estimate about 297,790 new cases of invasive breast cancer, and about 55,720 of ductal breast cancer in situ. That's the precancerous lesion. So, like I said, it's considered stage 0 breast cancer. So when should I get checked? So average risk women, which is a less than 15% lifetime risk of getting breast cancer, yearly mammograms starting at the age of 40. And that's wonderful that they are offering free mammograms. I just had my first one 2 years ago. And so it's great that they're offering that. Because I know during COVID, a lot of people did not get their mammograms and everything like that. Unfortunately, we saw more advanced cancers in our clinic because people couldn't go get their mammograms and stuff like that. Moderate risk women, 15 to 20% lifetime risk, mammograms at age 40. High risk women, greater than 20% lifetime risk of getting breast cancer. Those are yearly breast MRIs and mammograms starting at age 30. So we basically calculate risk based on this model called a Gale model. It takes into account certain things: your age at your first period, the age at the time of the birth of a first child, family history, number of previous biopsies for other things like a mass that was not cancer, number of breast biopsies showing atypical hyperplasia, which are abnormal cells, your race and ethnicity. Limitations is it does not take into effect if you've had breast cancer or something like that before. Personal history of a different type of precancerous lesion called lobular carcinoma in situ, which is cancer that has not left the lobules in the breast. And it doesn't take into account if you have a genetic mutation. High risk people are, as I said, a lifetime risk of greater than 20%, have a known mutation, BRCA2, it's based on some testing that you get done, have a first degree relative with this mutation and you yourself have not gotten the testing yet. If you've had radiation therapy to your chest between ages 10 to 30, there's certain lymphomas that are diagnosed when people are younger, and part of the treatment is radiation to the chest, the masses in that area, and that actually increases your risk of breast cancer. So this is kind of the guidelines for genetic counseling referral. If you are a person who has had personal breast cancer, if you're diagnosed younger than 50 years of age, if you have triple negative breast cancer, and I'll go over what that means, diagnosed at less than 60 years of age, personal history of 2 breast cancer diagnoses regardless of age, and then the known mutation. Multiple close family members with related cancers, diagnosis of ovarian cancer. Any man who gets diagnosed with breast cancer automatically gets referred for genetic testing, and anyone with Ashkenazi Jewish descent with a personal history of breast, ovarian, or pancreatic cancer. But if I'm being honest, most of our surgeons, we pretty much refer everyone for at least a genetic counseling evaluation, and they will determine if you do qualify for the genetic testing or not. It's just, there's mutations we don't know about that they may show down the line that they are associated with breast cancer. So we pretty much recommend everyone be referred for genetic counseling. So these are warning signs of breast cancer. I took this slide out because at a previous time I made a presentation, I had a slide that said most societies don't really recommend self-exams anymore because it shows that it has not increased the finding of the breast cancer or decreased mortality or anything like that. And everyone looked at me like I was kind of crazy because I said that. So I took that slide out because most of my patients still do their own self-breast exams because you've seen people get mammograms and 6 months later something pops up and they're not due for a mammogram until 6 more months. So I do encourage people to continue doing that. So new lump in the breast or underarm, thickening or swelling of part of the breast, irritation or dimpling of breast or skin. Dimpling meaning there's a terminology we use called like peau d'orange, which is orange peel. So if you ever look at an orange peel and it looks like little dimples on there, if you have an area of your breast that looks like that, that means there's something abnormal going on usually. So at least talk to your doctor, your primary care, or your OBGYN about that. Redness or flaking in the nipple area of the breast. Pulling in the nipple area, like you see the nipple kind of retracting in, that's an abnormality, or pain. And then any nipple discharge, if you're not breastfeeding or anything like that, if it's bloody or even if it's not bloody, talk to your physician no matter what age you are, or if you just had a mammogram and these changes pop up, talk to either your primary care doctor or your OBGYN. So these are just examples of the changes, the lump, the dimpling of the skin, how the nipple retracts and some of the discharge. So what can I do to decrease my chances of getting breast cancer? We talked about some that increase your risk: exercise or maintain a healthy weight, limit or eliminate alcohol consumption, avoid hormone therapy. That's really hard for people because the side effects of menopause are very hard, but avoid unnecessary medical radiation exposure, do not smoke, and then get your yearly mammograms. So I found a lump. Now what? Let your family physician or your OBGYN know so that a mammogram can be ordered. And then based on the findings of the mammogram, they'll do a biopsy. The tissue will be sent to the pathologist. They'll review what kind of abnormal tissue it is. And based on the results, your treatment plan will be made. Now, sometimes it can take up to 2 weeks to get all the results back. And, the waiting is torturous, but they want to make sure they get all of the information before they bring you in to talk about what the next plan will be. So there's different types of breast cancer. I mentioned these stage 0 breast cancers, ductal carcinoma in situ and lobular carcinoma in situ, which means it hasn't left and gone into the invasive breast tissue yet. And then invasive breast cancer, and then inflammatory breast cancer is the one where you see a lot of redness and that dimpling of the skin. That can be inflammatory breast cancer, and that's more aggressive. And these are other cancers of the tissue of the breast, but they're much less common. Paget disease of the nipple, phyllodes tumor, sarcoma, angiosarcoma, and lymphoma. So I have cancer, now what? Depending on the type of cancer and stage of the cancer, there are 3 different treatments. Sometimes you need all 3, sometimes you may just need 1 or 2. So there's 3 different surgeons. You'll hear this thrown around, surgical oncologists, medical oncologists, radiation oncologists. We are all oncologists, but we all do different things. So the surgeon will remove the cancer. I'm a medical oncologist, so I give the chemotherapy if needed or the hormonal pills if needed. And then my colleague is a radiation oncologist who sometimes you need radiation on top of surgery and treatment. So he's the person who would give that. So treatments, there's different types of surgeries. There's a lumpectomy where only the tumor is removed and then they conserve the breast. mastectomy, removing the whole breast. And then usually what they'll do is they'll do a lymph node removal. They will put some dye in the mass that's in your breast, and that will travel to the first lymph node. They'll remove that lymph node and see if there's cancer in it. If there's cancer in there, they go to the next lymph node, then go to the next lymph node to see how many lymph nodes are involved by cancer. So there's oral and IV treatment for breast cancer. There's chemotherapy, hormonal therapy, targeted therapy. It may be needed in all stages of the cancer. Testing on the breast tissue will help assist. Oh, I don't know what just happened. This is gone. Did I press something or? Okay, thank you. And then so depending on what kind of treatment is needed. So medicine that kills the cancer cells, that's what I give. It goes throughout the whole body. That's why you get side effects, because it's regular chemotherapy targets fast growing cells, which are the cancer cells, but also that's why some treatments you lose your hair because your hair cells grow fast. That's why your blood counts drop, because your blood cells are regenerated more regularly. And sometimes the chemo is given before surgery to help decrease the size of the tumor, or sometimes make the tumor completely go away. That can conserve your breast. So you just have to have a lumpectomy, and it can also save you from having all the lymph nodes removed, because sometimes after you get all the lymph nodes removed, you can get swelling in the arm because the fluid has nowhere to go. And so it's to try to help prevent that. And then radiation therapy is locally targeted way to treat cancer. So, and the side effects are usually like a bad sunburn to that area. It may be used after lumpectomy or mastectomy, depending on if you have lymph nodes positive or the extent of the disease. And then sometimes if you unfortunately have cancer that has spread from one part to another and you're having significant pain, like in your bones, radiation therapy can be used to help with symptom management for that. So, there are new drugs always in the pipeline for cancers, especially breast cancer. We do a lot of testing now. You can test your blood or the tissue to see if you carry any specific mutations. And based on those mutations, we have pills or IV medicine that targets that specific mutation. So sometimes you may not need chemotherapy. You may just need the hormonal or the targeted treatment. Depending on your risk, we can do preventative treatment for breast cancer. We have clinical trials available in our practice, but also you're in a great area, like DFW Metroplex has so many academic centers and so many clinical trial centers. So there's a lot of options. And so there is hope for the future. And, we have a better understanding now of breast cancer genes. So this is where I work. I work for the Center for Cancer and Blood Disorders. We have a lot of locations. I know it's really tiny up there, but lots of locations. I work in the Las Colinas and the Mansfield Clinic. We have a radiation office in our Las Colinas. We have a pharmacy. We have a treatment room. We have our own scan system and everything like that. For the center, we offer clinical trial support groups. We have patient family education. We have massage therapy, acupuncture, psychotherapy, quality of life clinic to help with pain management. And most of these are all offered free of charge to our cancer patients. So this is our group. And so if you guys have any questions, Dr. Brown will go first, and then we can address any questions that you may have.
Good morning, everyone. And I am Dr. LaTonya Robinson Brown. I'm a OBGYN, and I practice at Carswell Medical Center, which, as he already stated, can you hear me? Okay. As I've already stated, is at the only female prison medical center with the Bureau of Prisons that only focus on women's health care. There are some other centers that they have female inmates that are are at other facilities in the Bureau. However, we actually have a medical center that devote all the care for women. Do I start off? Can you hear me? I'm sorry. Okay, can you hear me now? Okay, I'll try to talk up also. I'm loud, I'm just not so loud today. Am I going the right way? Get the sticker up. And for the clicker as well. Okay. So the objectives of this talk is to understand the risk and the risk reduction of endometrial cancer. And endometrial cancer is usually called uterine cancer. That's the more common term that we all attribute to understand and detect the diagnosis of endometrial cancer, and to review the treatment options for endometrial cancer. So this is a diagram of the uterus, tubes, ovaries, and hopefully, can you hear me? Hopefully, I'm just gonna try to explain the diagram. There's several types of GYN cancers that can occur. A lot of times we say, oh, I have this type of cancer, but we don't really know exactly where. So you can, this is the vulva, this is the outside of the vaginal area. So we have cancer here, vulvar cancer. This is the vagina. This is where, doing sexual intercourse, insertion, and also tampons where they actually are. This is actually outside. If you look at this right here, go across here, this is all outside. Above this line, it's inside. This is right here, there's the cervix. That's actually the doorway to the uterus. And this is the what people always say that dilates when you get ready to have a baby. It dilates 10 centimeters to let the baby out. So that's the doorway, and you can get cancer there. Cervical cancer, that's where we have our pap smears, where that's all taken. We take a sample here and inside the very little area right here for your pap smears, and that's cervical cancer. When you go into the cavity, this is actually the uterine cavity. This whole structure is the uterus right here. And inside is the endometrium, which that's the endometrial cancer, which is the uterine cancer. And here, that's where we have the changes, and that's what we're focusing on today. These are fallopian tubes. This is where the egg is released. These are where these are the ovaries, and the eggs are made here. The egg is released each month, goes down the fallopian tube, and then if it's encountered with the sperm, it meets the sperm, and the egg will go together, and then it would actually implant in this endometrial cushy lining of blood that's here. If you do not get pregnant, or if you do not have a sperm that meets that egg, then this whole lining will shed and go out. Each month, this lining actually builds up. We have two hormones that make this lining build up. There's estrogen. That's the one that's most toxic to the uterus. Estrogen is the first one of your cycle. It builds up the lining. And then progesterone comes in and it stabilizes the lining. They bond together and they stabilizes this lining so they would be maintained so that egg can actually implant in here, and so that you have that cushy lining for the baby to grow. So progesterone actually protects our lining. A lot of the IUDs that we use are like Mirena IUD or progesterone only. And so that's when it's in there, that protects the lining. If you know about Mirena. So estrogen is the one that we always have to look out for. A lot of people make more estrogen than they make progesterone. And that's where the problem comes in with this lining. Over time, this lining will build up with estrogen. People will skip their cycles, they skip their periods. And it becomes common. They think that's normal, that they should skip that period, but that's not. you're supposed to shed this lining each month. But that is because sometimes they have more estrogen. And so this lining just builds up, builds up, builds up, it thickens. Over time, it can turn into precancer cells, and that precancer cells turn into cancer. Also, with the buildup of the lining, and it also, people will start to have shedding of that lining. That's why over time they will have bleeding, and they just continue to bleed. Like they skip them cycle over months, and then they just start to have bleeding and they can't stop. It's like it just won't turn off. And that's because that estrogen line, that lining has become so thickened, it does not have the vessels that the connection to the lining to support it. So it just starts sloughing off, and each month you just bleed heavy, heavy, heavy. And that's when you go to your OBGYN doctor. But usually any changes in your any changes in your uterine, in your cycle, you should go to your OBGYN to be evaluated. The most common GYN cancer in developed countries is uterine cancer. It's the 6th most common in women worldwide, and it's the 4th. Let me put it back over here. Yeah, because I don't want to start. It's the 4th most common cancer in the United States. Lifetime risk is 1 in 46. The mean age is actually 62. Anybody over age 50 and over, that increases your risk of uterine cancer. And you will find it also in younger premenopausal women, which women who have their cycles. 25% of uterine cancer can occur. And I've had patients who were 26 years old, 27 years old with uterine cancer. And the reason why they think that it's normal to have a cycle that's abnormal. They go for months and months without their cycle, and then not realizing that that's a problem, and they end up with uterine cancer early. And usually these patients, usually you can catch endometrial cancer early in their early stages. Hopefully I go the right way. Up. There we go. Okay. Some of the risk factors, obesity, and that's the reason why with obese patients, they have androgens which convert over to estrogens, and estrogens are the toxic ones that cause the lining to thicken and cause you to have uterine cancer over time. Diabetes, metabolic syndrome, people call PCOS, a polycystic ovarian syndrome. Have you heard of that? And so that is one of the risks that you may have also, because they produce more androgens, and estrogens are converted over to, androgens are converted over to estrogens, which help build up that lining, also cause cancer. Nulliparity, meaning having no children. So you have, if you have no children, then that means you have more lifetime exposure of having estrogen exposure. Late menopause, meaning that you have more estrogen exposure. Tamoxifen therapy, which is using hormonal therapy or used for cancer treatment, as she has just talked about, that's one of the ones that can also build up the lining of the uterus. Family history of colorectal and endometrial cancer, and also race. And unfortunately, African Americans have a high risk of endometrial cancer. Factors that protect against it, hysterectomy and combined oral contraceptive pills, which are having estrogen and progesterone. That's why you shed the lining each month. We have the estrogen that builds up the lining. Progesterone goes in, stabilizes the lining. If you don't get pregnant, don't have a sperm to catch that egg, then that lining just sheds. And so we need to combine oral contraceptive pills. Progesterone-based contraception, like the IUD or oral progesterone, that also protects the lining, because that's the pregnancy hormone. That's the protective hormone for the lining of the uterus. As I stated, the Mirena IUD, uterine devices, pregnancy also, less exposure to estrogen. Smoking, but don't start. That's actually protective. That's one thing that it is protective, not for lung cancer though. Exercise. exercising, and also breastfeeding. Okay, let me see if I get this thing right. There we go. Okay, risk factors, as we already talked about, obesity, increased conversion of androgens to estrogen by the adipose tissue. And that happens in the cells, the fat tissue, like obese patients have more adipose tissue. So that's where the conversion of the androgens converts into estrogens, and that's caused them to have more estrogen production. And so that's why weight loss actually helps in this case. Lifetime risk of diabetes, insulin and insulin-like growth hormone stimulate endometrial proliferation and increase the lining of the uterus. Unopposed estrogen, as we already talked about, exposure leads to endometrial proliferation and hyperplasia. Like I said, early menarche, earlier cycle start, nulliparity, and late menopause. Tamoxifen, as we already said again, and then Lynch syndrome. This is a genetic syndrome. It's an autosomal dominant syndrome that runs in families. A lot of times these patients, families, their multiple family members may have these types of cancers, and you can't pinpoint it until you actually do the testing. So you may have some people with endometrial cancer. You may have some people with colon rectal cancer. You may have some people in your family with ovarian cancer or even urinary tract cancer. And they do a genetic test to find out, when they do their genetic testing, like she talks about, they find out, oh, you have Lynch syndrome. And it may be scattered throughout your family, but during that consult, they find out that, they do the genetic testing, they find out you have Lynch syndrome. So that increases your risk also. Diagnosis. As we already talked about the abnormal uterine bleeding, changes in your menstrual cycle. Even if you have changes, like let's say you have your cycle, if it's more than 7 days, that's a problem. Less than 7 days, that's okay. But if you have your period and it stops, and then you start bleeding again in the middle of the month, and that is abnormal. If it's every month you're doing that, like you bleed your 7 days, and then after that you start bleeding again, that's a change in your menstrual cycle. You need to go see your gynecologist. Heavy bleed, like skipping your cycles, like we already talked about. If you don't have a period, go for months or 2 months. Some people say, oh yeah, I do that. It's just 2 months. Oh yeah, 3 months. Yeah, I go 6 months at a time, but that's normal. That's not normal. That increases your risk of uterine cancer. So go see your GYN doctor. Some of the symptoms are abdominal pain and distension. And that's, you don't see that a whole lot, but those are also some of the signs. And then there's some people just don't have no symptoms at all. They don't have that heavy bleeding like like they may have some spotting or something like that. And those are the ones that you are most difficult to diagnose. And also a late diagnosis and late prognosis. I mean, a bad prognosis. Pap smear, that's one way we find it. Actually, when we do the Pap smear, remember I was showing you the line in the doorway that opens up into the uterus? That's the cervix. Right in that little canal, you can have glandular tissue that's different than what's supposed to be there. And so on the Pap smear, you can actually find that gives you some indication that you need to do an endometrial biopsy. The endometrial biopsy can be done. The gold standard is using hysteroscopy, taking a camera and looking inside, and then doing your biopsy where you can look at the lining and see what's abnormal. But the most common one is in the office. You do a biopsy inside the office with a pipelle, and then we send it off to a pathologist. They look at it under a micro on the slide and see if there's any changes within the lining that's consistent with precancer cells or cancer cells. Pelvic exam. This was less likely you find anything unless there's really advanced disease, because it'll leave the uterus and actually go to the bladder or go to the rectum. That's when you really find some findings. Transvaginal ultrasound, and that's the bad, and not the one that you with the baby on the outside. Actually, it's like a little wand. It goes inside the vagina and actually more closer to the uterus, and they can actually look at the lining and see how thick it is. If it's less than, it says greater than 5 millimeters. Actually, we go by greater than 4 millimeters, because we want to catch those cancers early and then later. But that's one way also diagnosing. There are two types of endometrial cancers. There's type 1, which is more common, it's 90% cases, early diagnosis with these cases. And also, the condition is usually we have pre-hyperplasia, and that's hyperplasia is like the lining of the uterus gets thickened. And so we can find those cells early, and it's caused by increased estrogen. Type 2 is more difficult to diagnose. And type 1, you're going to see those people who are bleeding all the time. Type 2, you're not going to see that bleeding all the time type person. This is diagnosed like 10 to 25% of cases. Poor prognosis. And usually when you see the lining, when we take that, do that pipelle and look inside, you're just going to see atrophy, not a thickened lining. You're going to see just like a less of a lining there. So that's why it's harder to diagnose, because it's not a thickened lining. And uterine cancer, as you can see, if it's stage 1, it's really confined to the uterus. Stage 2 is the uterus and cervix. Stage 3 is outside the uterus, so it goes beyond the cervix. It interacts with the fallopian tubes, the ovaries, the bladder, the rectum, outside of the pelvis. At stage 3. And then stage 4 is moving to another area of the body. It goes to the lungs, goes to the bladder and rectum. And then stage 4, there's poor prognosis. Treatment is surgery, hysterectomy. We all know about hysterectomies. And there are different types of hysterectomies. There's the hysterectomy where people say partial, where they just take your uterus out. That's what they say, partial. And then we do the hysterectomy where we take your ovaries, and that's the tubes. And that's the we call the total abdominal hysterectomy. And that's ovaries and tubes. Then if it's more extensive stage of the disease, then you have modified hysterectomy. That's if it involves the cervix. And also it would be more the cancer people who would do this kind of surgery, where they're doing more advanced, taking more lymph nodes and all of that in the more advanced stages. There's radiation therapy, like she had just talked about, usually for stage 3 and 4 disease. There's chemotherapy for more advanced or recurrent disease. If they have already been treated and then it comes back, then we may use chemotherapy. Hormonal therapy is also used for recurrent disease, and usually these are progesterones that we talked about, the ones that are protective. And then there's targeted therapy also used. Oops. There. Yeah. Sorry. So overall, the prognosis, overall survival rate, for a 5-year survival rate for endometrial cancers for 80% of the patients. Usually it's one of the best ones. If you're going to have one, this is one of the best ones to have if you want to have cancer. Stage 1 is 87%, stage 2, 76%, stage 3, 59% survival, and stage 4 is 18% survival. The worst prognosis, these are more advanced disease. And we look at the grade, the type, the histology. That's more like the pathology. We look under the microscope, and we actually make a diagnosis that also gives you a prognosis of how extensive the disease is and how it can be treated. And prevention and screening. Oh, sorry. Oh, I'm struggling with this. Okay, oral contraceptives, the ones that I said, which contain both estrogen and progesterone. Intrauterine devices like the Mirena that we talked about, progesterone, which protects the lining. For Lynch syndrome, usually these patients have a prophylactic hysterectomy, and that means that once they finish having their children, that's when they have a total hysterectomy. They have the uterus, ovaries, tubes, all of that is taken out in order to prevent them from having endometrial cancer. And then there's no effective screening protocol, no non-invasive test for this type of cancer, which sometimes makes it harder to detect. That's why when you do have changes in your menstrual cycle, that's like one of the #1 causes. Don't wait, go ahead and get it checked out. Controlling your weight, blood pressure, diabetes, also to reduce the risk, meaning that weight loss, keeping fit. Restrict the use of estrogens after menopause if the uterus is intact. And that's what some people have hormones. That was one time we were given a hormonal replacement, and they were just doing estrogen and using it with people who had a uterus. That's not the right thing to do. If you have a uterus and you still have a uterus and have not had a hysterectomy, you will always have to have estrogen and progesterone hormonal therapy. If you do not have your uterus, then you can use estrogen because you don't have a lining to build up the lining that will cause and lead to cancer. And also, as I've stated over and over again, please go to your friendly GYN if you have any changes in your cycle to detect it, because that's the early detection. And I guess summary, I am closing. Endometrial cancer is the most common female genital tract cancer. Obesity, as we talked about, presenting in early stages, which has a good outcome if you go to your doctor early. Diagnosis is by the endometrial biopsy, either in the office, which is most common, or the hysteroscopy with biopsy that is done. Sometimes it can be done in your office, or it can be done in a surgery center where you do the camera that goes inside and take a look and take a biopsy. And then surgery is the mainstay of treatment, removing the uterus to get rid of the lining. And like I said, prognosis is very good if you catch it early. So any changes in your cycle, please go to your doctor. Thank you.
Right. Thank you so much. I know I learned a lot. I was telling my team, I can't wait to get home and talk to my wife and daughter. I'm serious. They always say, we ain't talking to you. This something. No, y'all talking to me now. I know the new stuff, the stuff that's coming out. But no, guys, we're getting ready to dispatch. Are we going to do Q&A? Or do we have time for Q&A? Can we do 2-3 minutes? Anybody have a special question? Okay, go ahead. Right.
Okay, can you hear me? Okay. Yes, thermal ablation is used. That's a technique that we use for people who don't know. We actually cauterize the lining of the uterus. If you have extensive heavy bleeding, we cauterize the lining to make sure that you destroy the tissue, the lining, so that you can't grow the tissue and stop the bleeding. This is like conservative therapy for those who have already been evaluated, making sure you do the endometrial biopsy, making sure there is no cancer there before we do those type of procedures. A lot of times we do the hysteroscopy. We have to take a look around, make sure that we don't see anything abnormal. There's no polyps or there's no precancer like thickening that you may see. We usually do that before we can do the endometrial ablation. But it's an excellent technique or procedure that a lot of women use if you're not ready to have a hysterectomy, or if you can't have a hysterectomy, some health condition would prevent you from having surgery. This is like a conservative option. However, you have to be evaluated before you can get that. And also, oh, I forgot. Also, a lot of times you have completed your childbearing. We want to at least try to make sure that you completed childbearing before we do those procedures. Also. Mm-hmm. 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 Yes. So long as you don't start back bleeding, like if you start bleeding, that means you need to go back to your GYN. Bleeding is the #1 indication of uterine cancer or endometrial cancer. So if you start bleeding again, go to your friendly GYN, let them check you out, because that may be a sign that that you may have it. Okay. I'm sorry. Mm-hmm. Mm-hmm. It depends upon your pap smear history. If you had any abnormal pap smears in your history, then you're more likely you have to have a pap smear continue having your pap smears because you're at risk. A lot of times you can have a reoccurrence along the cuff where we remove the uterus and then we sew you up. Right along that area where we sew you back up, you can have reoccurrence at the cuff. So that is why if you had any abnormal pap smears in the past, you might not be a candidate. Now, if you had never had an abnormal pap smear, then you may be a candidate, but you should always go to your doctor to be evaluated. Don't just say, oh, I'm not never going back there again. You want to go and be evaluated at least. And then you talk it over with your doctor and they make that decision. But a lot of women choose to, women are living longer now. We live into, 90, 80 and 80 is a new 70, 90 is a new 80. So, there are women who, and who are still sexually active. So, you can get vaginal cancer, as we talked about. You could get vulval cancer also. So you still need to go see your doctor. And a lot of times, vaginal cancer is picked up on a pap smear. So, you might want to choose to continue doing that, also. Yes, because you can get vaginal cancer, also. How you feel? You feel the same way?
Yeah.
Mhm.
For us, sometimes when women are in their 80s, sometimes their primary care doctors say you don't need a mammogram. And I have seen women in their 80s with breast cancer. So I really do recommend that you go every year because sometimes those women in those 80s are now living till they're like 90 something and they're very functional and everything like that. So we have screenings for a reason. Unfortunately, we don't have screenings for endometrial cancer, but for colon cancer, if you're a smoker, and you smoked a certain pack of years, now we have lung cancer screening. That's a newer thing, which we actually do at our center, and that's free of charge if you have smoked for a certain amount of time. And Pap smears. Those are all screenings. So they're there for a reason to prevent you from getting progressive cancer. So yeah, go get, if you still have any kind of risk, I would get checked out.
Yeah. Usually, actually, for Black females, actually 9.
Oh, yeah.
You can start your cycle at 9. Because now, for some reason, it's decreasing over years. I guess because we have better, I guess we're eating better, taking care of ourselves better. Back in the day, it was a little bit later it will occur, but now it's about 9 years old. So yes, it can be, you can start then. So that puts you at risk of having endometrial cancer because you're starting early, just like my 26-year-old. She may have started at 9. Never know.
Yeah, the same thing with breast cancer. It's all because of estrogen. Unfortunately, estrogen is protective for osteoporosis. It can help decrease your risk of osteoporosis. So we see that in our postmenopausal women when their estrogen is less, but it's also a risk factor for endometrial and for, breast cancer.
Like you say, estrogen does have some good stuff.
Some good stuff, but like it protects your bones, but unfortunately makes you feel better too. But unfortunately, the other thing.
Awesome. Let's give these ladies an amazing round of applause. Okay, make sure that you grab your gift bags. Like say you have your fanny packs and everything inside of that. So collect everything, be able to do that. And we have our next session that's going to be starting immediately after this. And we got Black Men's Health Matters that's going to be starting. Black Men's Health Matters. Y'all ain't got to run out now. Y'all need to go home and tell your husband about some of this stuff. I had to sit through y'all. Y'all need to sit through us.
Test.